I'm going to be speaking to you specifically today about attention deficit hyperactivity disorder. And what I'm going to be presenting to you has direct clinical implications, but it's going to be focused on research to try to understand what is the role of the dopamine system in the pathology, in the clinical presentation that you see in ADHD, and how does it influence the way that you treat them. And you say, well, why is it that I'm speaking about ADHD? And this is going to be work that reflects our research program on brain imaging, most of which has been taken place at Brookhaven National Laboratory, to investigate exactly that, the dopaminergic system in attention deficit hyperactivity disorder. And why did we get interested on it? And I mean, as you sort of says in my brain, the reason why I got interested on it is because of the collision that you have between ADHD and substance use disorders. And it comes from two different highways, if you want to know, and they both of them collide, implicating that this is a phenomenon that is telling us something fundamental about ADHD itself, its neurobiology. The first one of them has to do with the fact that the use of drugs is significantly higher among individuals that have ADHD. And you see that among adolescents as well as adults. And this is a recent publication from Levy et al. In 2014 that actually looks at the prevalence of the substance use disorders between ADHD cases and controls. And you can clearly see whether it is in adolescence or adulthood, the prevalence is much higher. So the question about it is, what does it mean? Is it just aleatory randomness? And when you have findings like these ones, which have been consistently reported by independent investigators, even after accounting for the high comorbidity of comorbid disorders in ADHD, you still have a higher risk for substance use disorders among those that have ADHD. So what is it telling us? Why is it that they are more vulnerable to taking drugs, these individuals that have a diagnosis with ADHD? So that's one of the highways that collides these two fields, the clinical presentation. And what is the second one that collides? The most effective treatments that we have, medications for ADHD, are actually drugs, stimulant drugs, that also by themselves can be quite addictive, if of course used outside the medical context. And so, and what I'm putting you there is pharmacologically, on the top, two of the most addictive drugs that we know of are cocaine and methamphetamine. In fact, if you were to ask me which is the most addictive drug based on its pharmacological effects, I would say methamphetamine. And based on its clinical presentation, in terms of how rapidly, if you start taking a drug, is it that you're going to get addicted? And in terms of number of people that become addicted once they start taking it, I would also say methamphetamine, followed closely by cocaine. Now, chemically, why is that so? Because methamphetamine, of all of the drugs of abuse, is the one that has the highest potency in increasing dopamine in brain reward regions. And increasing dopamine in brain reward region is the mechanism by which all of the drugs of abuse, whether they are legal, like cocaine, legal like alcohol or nicotine, or illegal, like cocaine and methamphetamine, exert their rewarding effects and produce the phenotype that we call addiction. And the phenotype that we call addiction is the loss of control over drug taking. But the ability of drugs to increase dopamine in reward regions is what makes them rewarding and potentially addictive. Well, look at methamphetamine, its chemical structure, and then compare it with that of amphetamine, and you can basically say that they're almost identical. And not surprising, amphetamine is highly addictive. It's almost as addictive as methamphetamine when you give it at high doses, when you give it by routes of administration, such as injection. And there are many countries that have struggled with epidemics of amphetamine addiction. One of them, for example, is Japan. And again, amphetamine can be highly, highly addictive. And yet it is therapeutically quite useful in managing ADHD. So here we have a drug with a very dark side to it, its addictiveness, and on the other one, its potential therapeutic effects. And we don't want to remember history sometimes because we don't necessarily know how to explain it. But methamphetamine was an approved drug for the treatment of ADHD. And for many years, methamphetamine was one of the medications that was used for treatment of ADHD. Now that is basically a long time ago and nobody seems to remember. But methamphetamine and amphetamine as pharmacological agents don't differ very much. Now let's look at methylphenidate, which is the other very frequently and the most frequently prescribed medication, stimulant medication for children globally. In the United States, we seem to medicate children also a lot with amphetamine, but in Europe and in many places in the Orient, in South America, the drug of choice for children as a stimulant is methylphenidate over amphetamine. Well, interestingly, methylphenidate, pharmacologically, if you look at its characterization in terms of where it binds, its targets, its characteristics are almost identical to those of cocaine. And indeed, when you are doing experiments where you actually want to give a drug and determine how similar it is to cocaine, the way that you do it is you have a monkey press a lever and you can change it. And monkeys don't differentiate intravenous cocaine from intravenous methylphenidate. And cocaine abusers don't differentiate intravenous methylphenidate from intravenous cocaine. So you have cocaine and methylphenidate being very similar, and methamphetamine and amphetamine being very similar. So what is it telling us? I mean, one of them, people take it when they are abusing them because they want to activate the dopamine reward system. And the other one, we prescribe them because we want to improve the ability of children to pay attention. So, but is that rewarding, the activation of that reward system important on ADHD? And why would it be important just to start with? Is this a chase that will lead us nowhere? Well, what we need to understand is that biology created the reward mechanism, and this reward mechanism, which is stimulated by the dopaminergic systems, by dopaminergic neurotransmission, is evolutionary conserved, which means that it works, and it works extraordinarily well. And through reward, biology motivates our actions. And that is where the issue becomes very relevant for ADHD. When you stimulate the dopamine system and something is rewarding, it motivates our behaviors to actually engage in that particular task. So reward is fundamental for motivating our actions, whether these actions may be to go and purchase a book that we want to read, or it motivates our actions in sustaining attention because you want to actually understand, in this case, what I'm saying. That ability to motivate behaviors, whether it is a locomotor action, or whether it is eating, or whether it is sustaining attention, requires these dopamine reward systems. And that's where the two fields are colliding. So dopamine, obviously, we know it's involved with movement. We know it produces a sense of well-being, and it motivates our actions. And I think that it is with that motivation, things become very uninteresting. Involved, therefore, with attention, implicated, and involved with addiction. So let me just guide you to the methodology that we have used in order to investigate this phenomenon of the involvement of this dopaminergic reward system in attention deficit hyperactivity disorder. We use a technology called positron emission tomography that images the brain. And the imaging of the brain is based on the injection of a very small quantity, a tiny, tiny quantity of radioactive compound with a very short half-life, 20 minutes. And we can vary the compound that we want to look at, but for actually monitoring dopamine, the reactivity of the dopamine system, or the ability of drugs like methylphenidate, Ritalin, to increase dopamine, we use a compound that is labeled with carbonyl label called raclopride. Raclopride binds to dopamine D2 receptors, and you see a diagram showing a synapse. And a synapse is basically where two neurons get together in order to close together to pass a message. One neuron is going to release a chemical that will then travel and activate the receptor in the other neuron. and that initiates the message. And the way that in this case, dopamine is liberated from one cell and then binds to a receptor in the other side. It has to bind to a receptor in order to trigger the action. That's exactly what raclopride binds to, that receptor that is necessary to transmit the action. Except that this raclopride only binds to the receptors when they are not occupied by dopamine. If there is a dopamine molecule binding to that receptor, raclopride will not bind. So you see two images there. One of the raclopride where it goes normally when you do not have a drug on board, and the other one when you get the raclopride after you have given that drug, which in this case is methylphenidate Ritalin. And in this case, for this particular study, it was given intravenously. And this is a very important distinction that I want you to be aware, and I will come to it later. This was a specific study where we gave intravenous methylphenidate. And intravenous methylphenidate, just methylphenidate in general, you all know how it works. It basically, methylphenidate blocks transporters, dopamine and norepinephrine transporter, it blocks them. Now, what is the function of a transporter? A transporter, what a transporter does is it basically removes the dopamine, in this case, the dopamine transporter, removes the dopamine that has been liberated. It brings it back it recycles it back into the terminal, into the dopamine cell. And by doing that, it terminates its action. But if you get a drug like methylphenidate, or if you get a drug like cocaine, exactly the same thing. This blocks this transporter and dopamine accumulates so it can bind to the receptors. And that's why when raclopride is given, the binding is down. And you can do this type of experiments and give the intravenous methylphenidate to subjects and ask them, how are you feeling? How intense is the high that you're getting from this intravenous methylphenidate? Because you do get a high. If you inject intravenous methylphenidate, you get a high. Actually, it's as intense as that of intravenous cocaine. And what we showed many years ago, and others have shown exactly the same phenomena for intravenous amphetamine, is that the higher the increases in dopamine produced by intravenous methylphenidate, or the same thing was reported for intravenous amphetamine, the more intense the subjective perception of high, indicating that increasing dopamine is associated with rewarding effects in humans. And in this case, both for methylphenidate and both for amphetamine, but when you inject it intravenously. And we don't give methylphenidate or amphetamine intravenously, we give it orally. And in fact, it's not that we had not known that methylphenidate could be addictive or that amphetamine could be addictive. We knew that because there had been an epidemic of abuse and addiction to methylphenidate. But people were actually, the explanation that they gave is that when people became addicted, they were actually either snorting their methylphenidate or they were injecting it. And they say, whereas when we treat, we give it orally. And when you get it orally, it is metabolized into ritalinic acid. And it was postulated that ritalinic acid has very low affinity to bind to the dopamine transporters. And that's why it's not addictive, why oral methylphenidate is safe. So we decided, and because they say it's not increasing dopamine very much in the human brain. And in fact, some people were postulating that oral methylphenidate would decrease dopamine. And I can ask you what the logic was, why they thought it could decrease dopamine, if you ask me the question. But let's say most people said the reason why it's not addictive is it's not increasing dopamine to any significant extent. And so we did the experiment, and here you have on the top panel the subjects when they actually are getting a placebo. You see the red colors indicate a higher concentration of the receptor here. And then, so this is where it binds. This is just for non-specific binding. And then you give them oral methylphenidate. So this is not intravenous methylphenidate. And you can clearly see that the raclopride binding is going down. This is the scale. Why is it going down? Because dopamine is occupying those receptors, so the raclopride cannot bind. So oral methylphenidate increases dopamine. Interestingly, look at it. It does increase, and these are all of the participants, changes in dopamine, but it does not produce a high. And this is, of course, extremely different from what we observe in here, where you actually see that the higher the changes in dopamine, the more intense the high. And the amount of increases in dopamine that we observe in some of the participants given oral methylphenidate were of a similar magnitude to those that we were recording when we had given intravenous methylphenidate. But they were not getting the high. So what is the difference? And again, this is another extremely important factor that is determining why we can use these medications safely without producing these addictive behaviors unless we go into very, very high doses. The fact that we are giving them orally, and even though they are metabolizing into ritalinic acid, they are still very potent stimulant medications. But what is the difference? The difference has to do with what we call pharmacokinetics. That is, the speed at which the drug gets into the brain. When you inject intravenous methylphenidate, and you have it here using imaging where we label methylphenidate with carbon-11 and we monitor its distribution in the brain, we see that intravenous methylphenidate gets into the brain very, very rapidly. It's peaking around before 10 minutes, but you see an extremely high content of methylphenidate going in the first 5 minutes. In contrast, when you give oral methylphenidate, you are not going to get peak concentrations in the brain until 1 to 2 hours after you administer. And you're going to say, well, why is this important? Well, this is fundamentally important because dopamine cells actually signal in 2 modes. One of them is the tonic mode that leads to constant, relatively low to moderate levels of dopamine, and that is what we call tonic. It's what it provides us a baseline. It makes us receptive. That baseline is what drives you, what it sustains our attention. But it is not per se that association linked with a reward or a high. On the other hand, when something very rewarding or unexpected or very salient happens to us, we're not expecting it, something. Like you, for example, someone gives you something to eat and you've never had it before and it's extraordinarily delicious. That's unexpected, rewarding. Dopamine cells start to fire very, very rapidly. And that leads to a very fast increase in dopamine. And that is associated with reward. And that creates a memory, not a conscious memory, but a memory that would lead you to want that stimuli if you are exposed to it again. So you learn on the first exposure when these phasic dopamine cells fire. And you create then a trace that will guide your behavior. And that's why drugs are actually so extremely harmful and dangerous, because they are emulating exactly the signaling process that is occurring with this very fast dopamine firing that results in these memory tracers. If you give a drug orally, it goes very, very slowly, and you never get these very sharp dopamine increases associated with a phasic mode of signaling of the dopamine system in the reward systems. And that is actually exactly why we can treat children or adolescents or adults with oral methylphenidate or oral amphetamine. And again, I emphasize again, provided that you don't get huge doses. You get huge doses, you may get very sharp increases very rapidly because of the slow pharmacokinetics. So how does this in any way have to do with a sense of therapeutic benefit? And as I say, the phasic dopamine is going to create this memory that's associated with saliency. But the tonic dopamine is going to actually engage you and sustain your motivation to perform a task, to keep doing what you are doing. So we actually then decided, I mean, a lot of people sort of the classical mode about why people say stimulants work, they say, well, they improve attention. But to me, one of the things that happens when you actually give anything that increases dopamine in your brain, something very curious happens. Things are perceived as more salient, more interesting. And that's the way it has to be. When you have signaling, this tonic dopamine signaling with some of the phasic dopamine going in, things are actually going to engage you more. And that's the way that nature ensures that you will pay attention to salient events. It activates that dopaminergic pathway on the reward system. So we wanted to know, could it be that methylphenidate makes things more interesting and exciting? Think about it. And could it be then, therefore, that that's the mechanism by which it improves attention? And that thought came to my brain one day when I was listening to a talk, and it was a very boring talk. And it was a talk. I mean, it was even worse than that because it was a talk on ADHD. And even though it was on ADHD, which I study, it was not salient enough for my brain. And I was very, very bored. And I was upset because I was forcing myself to pay attention. So I said, Nora, go out and get a cup of coffee. And yes, coffee will activate these dopaminergic pathways and make things more interesting. And that's when I realized I can basically make things more interesting just by drinking a cup of coffee. But that's my brain, right? I mean, I cannot equate everybody with that same responses. So I try to convince my colleagues. Actually, I had been working for many, many years at that time with Dr. Jim Swanson, who has schools for children. And I said, why don't you just ask children? Is the task that they are doing more interesting or exciting when they take their methylphenidate, not just focus on doing whether they do better or not. And I couldn't convince him, so I said, okay, I'm going to do it myself. And we did. And now this study that I'm showing you and all of the studies that I'm showing you, I do want to make a caveat. They are done in adults. And because we use positron emission tomography, which requires radioactivity, we cannot study individuals that are less than 18 years of age. So all of them are adults with ADHD, and this particular study was first done in individuals that were healthy controls. We gave them a mathematical task with placebo, the same mathematical task with methylphenidate. We measure the changes in dopamine produced by methylphenidate, and we assess whether, in fact, methylphenidate changed their perception of the task as an exciting, interesting, engaging. And these are the results of this paper, which we published many years ago, almost 10 years ago, in which we actually show that, indeed, in terms of the self-reports, these adults that were given methylphenidate were reporting the mathematical tasks that we were asking them to do to be more interesting and exciting when they were on methylphenidate. And that was actually quite significant. And we also showed that, again, we had shown before that methylphenidate increased dopamine. But what we showed was that the magnitude of the increases in dopamine triggered by methylphenidate were directly associated with a subjective perception that the individual have of the task being more exciting or more interesting or more motivating. And I'm showing you for two of those scores, interesting and motivating. And you can see the more motivating that they felt with respect to the placebo, the larger the dopamine increases methylphenidate was able to do it. So that proved our hypothesis that indeed the increases in dopamine produced by oral methylphenidate in our brain, and these are healthy controls, are going to make the task appear more interesting and motivating. Of course, you have to put it in context that this effect is likely to vary very much as a function of the nature of the task. Because if you are doing a task that is inherently very salient and interesting, giving more methylphenidate may not necessarily improve it. This is likely to be particularly beneficial, and again, we're speaking on healthy controls, when you are doing a repetitive, boring task, where that dopamine enhancement will make it more salient. And I'm putting this forward because, as you know, there's been a lot of interest and a lot of diversion of methylphenidate and amphetamine among healthy teenagers in order to improve their cognitive performance, with the notion that they will get better scores on their exams. That's not necessarily correct. It depends. They will be able to study better if what they are studying is very boring, but if it is not, they actually can worsen their performance. So that was in healthy control. What does this have to do with ADHD? Is there any evidence that there are impairments in motivation on ADHD? And I would say yes. There's been several clinical papers that have eloquently discussed this, provided evidence for this effect. And there's also, this has been targeted as one of the approaches for treatment interventions to enhance the motivation of children with ADHD. Behavioral interventions have been shown to be beneficial. So we do know, but how does that relate to the dopaminergic system? Well, we decided to see, first of all, is there any evidence? Why would these kids then benefit from stimulants Is there evidence that their dopamine reward pathway is not functioning properly? But that's in ADHD, that's what you want to know. And could it be, therefore, if they are not functioning properly, that underlies their deficit in motivation, and therefore it would make a lot of sense to give them a stimulant medication? So this is a study that took us several years, something like 7 or 8 years to complete, because we wanted to get, these are adults with ADHD, we wanted to have a sufficiently large sample size that will enable us to unequivocally assess whether there's any evidence that there are changes in markers of the dopaminergic signaling system in the brain of individuals that have ADHD that have never been treated. And this was important because we knew that the use of stimulant medications actually leads to neuroplastic changes in the dopamine pathway. And we wanted to actually not have that confound. So we were able to finish this study. It was done in collaboration with UCI, Jim Swanson, with Scott Collins, and with NYU University. And what we did for this particular study was we tested individuals with 2 PET markers, one of the dopamine terminals, the dopamine transporters, and the other one of the postsynaptic cells, the one that are going to receive the message from dopamine in the striatal regions, including their reward center, which is the nucleus accumbens. These are images actually for C11 cocaine on a control subject that was also tested with C11 raclopride for measuring the dopamine D2 receptors, that marker of the postsynaptic. So you have the presynaptic with C11 cocaine, which measures the dopamine transporters, and the postsynaptic, which measures the C11 raclopride. In this particular, these are individual subjects. So, but for this particular group of images, what I'm showing is that in this case, the ADHD subject had lower levels of dopamine transporter than the control. And, but it doesn't seem to have differences in dopamine D2 receptors on those planes. And I'm highlighting and showing you this image because there's been a series of papers that came out and saying you have ADHDs have increased levels of dopamine transporters, and this is a biochemical marker of the disease, and blah, blah, blah. No, I wish it were. It would be fantastic. And I'm showing you an individual who has ADHD that doesn't have increases in dopamine transporters. It has decreases in dopamine transporters. So it's not a marker, the dopamine transporter, and there's tremendous variability. There are some individuals that have low levels of dopamine transporters and others that have normal or perhaps slightly elevated levels. But at the group level, what do you find? And what we, just to get you a perspective of the methodology, when we sample the brains, these are the regions that we sample. And we sample them because this is where you predominantly have the highest density of dopamine transporters. That's where the dopamine cells that express transporters project. In the striatum, in the yellow and the areas, which is the putamen, the blue area is the caudate, which is consistently implicated as one of the areas that's abnormal in ADHD. The purple areas there are the famous nucleus accumbens, the ventral striatum, where the reward centers are located, the dopamine reward centers. And the brownish area is the midbrain, where you actually have where the dopamine cells reside. So when you quantified in this large sample of individuals for a PET brain imaging study, it's actually quite large, are there differences? Well, what we found was very interesting, and it's summarized in those 4 images over there that show the areas where both dopamine transporters, markers of the terminal, and dopamine D2 receptors, markers of the postsynaptic sites, are decreased in ADHD participants. No area showed increases. There was no area in the brain of ADHD where these markers were increased. And what was fascinating was that the effect was very restricted to the ventral areas of the striatum. And it included the famous nucleus accumbens, but it also included the ventral caudate, which again is one of the regions that has been most consistently associated with inattention in ADHD. And but what was surprising to us was that the defects were being observed both in the dopamine transporters and in the dopamine D2 receptors, which in my brain, and again, my brain may not necessarily be the only explanation of things, but for my brain, the explanation that I gave Why would you have a decrease presynaptic and postsynaptic? If you damage these, there's an increase in receptors. That's the way that normally neuroplastic has. But if you don't have innervation, then of course that could explain why there is a decrease in here and that associated with a decrease here. So one of the interpretations that we had is that the pathway, the projections of the dopamine cells are less in individuals with ADHD in this area of the ventral striatum, which is basically implicated with reward and motivation. And in this, since we were very interested on knowing how this, is this in any way related to the motivation deficit that other investigators had reported on ADHD, we then did what was obvious to do, are the measures on dopamine transporters and dopamine D2 receptors in the nucleus accumbens associated with measures of motivation in individuals. And you can see that indeed they are, whether it is the dopamine transporter or the dopamine D2 receptors, the lower the levels of these markers, dopamine markers, markers of the dopamine synapse, the lower the levels, the lower the motivational scores in these individuals. And in the lower histogram, you see over there, the average measures on this motivation as state measure, actually it's a trait measure of motivation, in controls and in ADHD participants showing the significantly lower values on ADHD participants. These are adults. It had been documented in children. I think that I do not know the extent to which this had been documented on adults when we first published this paper. And so to us, what it was telling us is that there is a deficit in these ventral striatal areas in ADHD, certainly in adults with ADHD, that is driving the deficit in motivation. Is this accounting for symptoms of inattention? And the answer is yes. And so what you see here are basically the histogram between this measure of motivation and the symptoms of inattention, whether you do it with the CARS A or the CARS E or with the SWAN, which allows you to measure not just for symptoms of inattention, but also for performance over the normal. So in the SWAN measures, you get symptoms here, and the opposite of the symptoms means that you're actually able to pay attention and sustain attention beyond what is expected. And again, the lower your motivation, the more the serious severity of the symptoms of inattention, indicating that these two symptoms are related and are mediated in part through the dysfunction of this dopamine reward motivation pathway. So is this, can this predict treatment? So if we are claiming that that deficit in the dopamine ventral striatum, where the nucleus accumbens is located and the ventral caudate, if that is a crucial deficit on ADHD, then it follows, if we are right, that if we treat individuals with ADHD with stimulant medications at the doses that we use clinically, and we evaluate the magnitude to which their symptoms improve, if we are correct, then the increases in dopamine produced by the stimulant medication in the ventral striatum should predict the improvement in the symptoms presentation on ADHD. So that's what, in our brain, we ask the question. Question number one. But question number two, also, we wanted to know, too, because, again, I come from collision of these two fields, substance abuse and ADHD. In substance abuse, what we had seen, and others had seen, is you give cocaine or you give methamphetamine, you actually downregulate pretty profoundly the dopaminergic signaling system. So you actually decrease, even though when you are intoxicated, dopamine is flooding all over your brain. When you are not intoxicated, it goes down. So a question that we had always wanted to answer is, when we give a stimulant medication chronically, does it have this negative effect of downregulating the dopaminergic signaling mechanism in our brain? And it's important to do, and we had never done it, so it's a very difficult study to do, but we bite the bullet because we thought it was important, and we did it. Again, collaboration from UCI, Jim Swanson, Scott Collin, and NYU. First of all, we took individual adults with ADHD, had never been treated. Again, we put ourselves onto very difficult, complex things. And then we treated them with 1 year with Concerta. That's it. Basically, we slowly ramp up the doses until they were stable, and we kept them and monitored them for compliance for 1 year. And when they were stable on their medication, we tested at the end of the year, but they were on medication when we tested them, their symptoms with the CARs. So what you are seeing here are the different scales of the CARs. When the participants were first recruited, they had never been medicated. And then towards the end of the year, when they have been on medication, but they are on medication when we test them. So their symptoms are significantly improved, as you may imagine. Big mistake, you know what we didn't do, which was a horrific mistake? We should have tested them at the end of the year when they were not under the influence of the medication. I wish I had thought about it, but I didn't. So we don't have the data, and so if you wanted to ask me, you already know the answer. No, I don't know. But the question was, are there changes in the measurements of dopamine increases, as I show you how we do the measurements of dopamine increases 1 year later? Okay, so here it is, what we didn't want to see, but you do experiments. Sometimes you don't necessarily like the data, but that's what you get. The initial visit is in the very dark blue, and then on purple is purplish, light blue is the 12-month visit. In the images, you have the naive treatment. It says placebo, and then IV methylphenidate. These are average across all subjects, so I'm not picking up one. And you see the very significant decrease in the red, in the striatal areas, because yes, intravenous methylphenidate, by the way, is decreasing the binding of raclopride since it's increasing dopamine. Now compare the images just visually, but you can do it because they have been transformed and they are average. You can actually extract the finding from it. And if you compare the upper and the lower one, you can see that this appears to be attenuated. The response of IV methylphenidate is attenuated after 12 months. And when we actually do the statistical analysis for percent change, you have in caudate, the first visit, the second visit. In putamen, the first visit, the second visit. And in this region of interest analysis, the ventral striatum is also attenuated, but the variability is so large, this is not significant. But if I do a statistical parametric mapping where I don't pre-select regions, but let the data show me, here it is, different levels of the brain, like an horizontal, as if you were slicing it, from the lower part where you have actually in the first image over there, that's where the nucleus accumbens is located, that one. My here thing. Here, there you have it. Nucleus accumbens is between these two here. But you see a very consistent increase in dopamine throughout the striatum. This is the first scan, okay? Let's look at them, and again, average across all of them, 12 months later. And the data speaks for itself. You can clearly see, without being an image expert, that this is much less than that. But you apply the statistics so that no one complains. And then you observe these are the areas where you have a significant difference in the magnitude of the dopamine increases produced by methylphenidate. And that actually, in this, we can clearly observe the effects, not just in caudate putamen, but also in the ventral striatal region. So unfortunately, with repeated use of methylphenidate, you actually become tolerant to the ability of this stimulant medication to increase dopamine throughout the whole striatum. And this could explain why it is necessary to increase the doses in order to get the same therapeutic effect. There's no ways around it, and I wish it weren't like that, but the data is very, very solid. The effect size is quite large, and you see it consistently in all of the participants. What I don't know is how long-lasting it is, and that, again, would be something that would be very, very important to do. In other words, if I take a person that has been on 1 year on methylphenidate, and I stop the medication over 1 month, will it recover? Will it recover over 1 week? How long would it take? And that is important because that would be clinically useful. It could help us guide if you have a patient that's not responding anymore to the methylphenidate dose and you have increased and you don't want to increase any further. You would want to know, should I give a window and then try? And if I give a window, for how long? And also, are there ways of administering the medication that can minimize the development of this tolerance? So in kids, for example, would it make sense to have every month, to guide yourself, to be able to guide? Is there something, if I don't do it on weekends, will that prevent the tolerance? And right now, I don't have the slightest idea. And this is, again, something that would be, obviously, could be done clinically to try to see if you do have tolerance. Can you reverse that tolerance? And using imaging, of course, it could help you guide you specifically where, in fact, that tolerance is related to the fact that your ability to increase dopamine is being decreased by the drug. Actually, this is what much more severe, what you see in people that are cocaine abusers, a profound attenuation of these effects of stimulants. So it's much worse than what we're seeing here with 1 year. Now, how about these changes in dopamine? If we can monitor now exactly we ask the question in the brain, the whole brain, and says, there were changes in dopamine in the brain, which are the areas that actually predict the clinical response of these patients to the therapeutic dose of methylphenidate, Concerta. So we scored them, and the changes, the delta in their symptoms when they get this actually Concerta. So these are the clinical measures, the naive and the treatment. And you use this delta, and you ask the brain, you ask the statistical package, tell me where in the brain is this a correlation, is there a correlation between the changes in symptoms, the decreases in the symptoms, and the increases in dopamine? And what's striking is basically in the ventral striatum. So it is indeed the ability in these participants of methylphenidate to increase dopamine in the ventral striatum that is predicting the improvements, in this case, actually, specifically, of symptoms of inattention. It does not predict their improvement in symptoms of hyperactivity. It is specific for symptoms of inattention, indicating, indeed, that the dopamine reward system, through its effects on motivation, is likely to be playing a fundamental role in both the pathology that you see in ADHD, through its dysfunction, making things less salient, not generating the attention, not engaging and sustaining the attention for one hand, but also on the therapeutic benefit that individuals have when they take methylphenidate or amphetamine. It's going to enhance therapeutically dopamine signaling in this pathway, and it's going to facilitate the motivation and drive, that stimuli that may not be inherently motivating, like a very boring teacher in the class, to engage and be able to actually perform and do repeated tasks like you need to do when you have to do homework. So this is where we are. I mean, we focus enormously on the inattention component of ADHD. Based on our findings, we would like to say that the deficit in motivation is as important as the deficit in attention in ADHD. And that targeting specifically that motivation deficit would be important in terms of clinical therapeutics, and may also be important in preventing the use of drugs in these children or adolescents that may have ADHD, that are not properly treated, that then may be taking drugs which will activate that motivation pathway in order to compensate for this deficit. And that I want to borrow actually a slide from Dr. Collins' presentation, in which he actually postulates a model by which having genetic vulnerability markers that increase your risk for ADHD are also increasing your risk for substance use disorders. These markers relate to the function of the dopamine reward system, and that lead to a deficit. And if improperly treated, these kids or adults may start to experiment with drugs, and without them recognizing it in a conscious way, may be, while they are intoxicating, performing better. But unfortunately, this leads them to the more drug taking, and that puts them into that trajectory of addiction. And with that, I want to thank my colleagues at Brookhaven National Laboratory, without whom this work would have not been possible. This is a team of very talented investigators from very, very different disciplines, as well as my colleagues at UCI, at NYU, and Wake Forest, and the National Institutes of Health. And I want to thank you for your attention.